I'm going to let Shireen take over. Thank you very much for joining us.
Thank you, Beth. I thought technology was supposed to make our lives easier, not more challenging. So since I'm technologically challenged myself, we will move ahead and figure these things out as we go along. Hello, everybody. Thank you so much for choosing to spend this Friday afternoon with us talking about one of my favorite topics, which is recovery. And we're going to be doing so with a twist today because we're going to be talking about organizational recovery and how we can begin or continue that transformation process within our own organizations to be more recovery-oriented. I'm going to share just a little bit about myself to give you context of what my perspective is going to be. As Beth said, I'm the director of Mecklenburg's Promise. I started the organization about 5 years ago at this point, and there are several reasons why I thought a peer-operated recovery education entity was needed in our community. We recognized at that time, and maybe some of us still do have this situation occurring, that we have a mental health system that really has been in crisis. When I look around what's going on in behavioral health care, I still see a lot of paternalism and an illness-based dependency type of approach. And I relocated to North Carolina about 6 years ago, saw this occurring and said, I can't be a part of this. I really need to work to shift our organizational understanding of recovery and our system belief and understanding of recovery. So the lack of awareness, the lack of understanding, and certainly the lack of belief in wellness and recovery is part of what prompted me to start Mecklenburg's Promise. And like so many people who have lived experience, I have been very fortunate to use my personal recovery experience to work within organizations, work within systems, and to try to make the system a little bit better, and to demonstrate that recovery is absolutely possible and probable. I also have had the wonderful opportunity of working in a variety of different areas within the field for 16 years. I worked in traditional settings, inpatient programs, clinical settings, and I've worked in very recovery-oriented organizations and systems. I learned a lot over the years what does work, and I've learned a lot about what doesn't work, and I wanted to be able to share some of that information. I saw a lot and continue to see well-intentioned clinicians who either burn out or just go along with status quo. And I think there are a lot of reasons for that, some of which we'll talk about during this webinar, but that really prompted me to say we need to make some changes because peers, the way that they are receiving services and the people that they receive services from can really help or hinder the process of recovery. And of course, I've learned so much, the most from people throughout the years who've allowed me to be part of their recovery journey. When I started Mecklenburg's Promise, I really debated about whether we should just work within the peer world and strengthen peer support in the peer community and peer leadership, or whether we should also work within the organizations. And I made the decision to bring both sides together, partly because I have both sides as a part of who I am and my experience. And the other part is I feel like peers come in contact with service providers a lot. And if we don't make efforts to try to transform that system, there are many people who are not going to have the benefits of recovery. And so we provide at Mecklenburg's Promise technical assistance, training, recovery education. We do a variety of different initiatives in our state and local community, all about transforming the system toward recovery, and we offer peer support. The other piece of information that might be helpful relative to background is that I also am a consultant. I focus a lot on program development and system transformation. I do consulting for peer organizations, behavioral health organizations, and for mental health systems. And as Beth said, I've been a consultant for the council for the past 9 months, which has been wonderful and has added to my experience. So I really appreciate that. So as Beth talked about earlier, there is an icon that looks like a little hand, and I want to ask you a question and just get a sense of who we have with us. So how many people that we have present right now either represent a county, a state, or federal oversight entity? If you could find that icon and use show of hands.
Shireen, it looks like we have about 2 people of the 30 who signed on.
Okay. And I'm seeing a few more people finding their hand icons, so it looks like we're up to about 5. Thank you. How many people present represent a service provider organization?
Quite a number more, closer to 10 or 11, it looks like.
Okay. And then if you click that hand icon, it will put your hand down so that we can start the screen. So if you could do that, that would be great. How many people present represent a self-advocacy or a peer organization? Self-advocacy or peer organization? Wonderful. It looks like we have a few.
Yeah.
Great. And how many people represent a university, research institution, or a training entity?
I see 1 or 2, it looks like, Shireen.
Okay. And then any others that I missed? You can either write it in the chat or write it in the question button.
Well, I know we have a few CQL staff on here, so.
Okay. Well, we have a pretty good mix. We actually ended up having 73 people register from all over the country. And when you have a group of people that's that large, and obviously from diverse backgrounds, it can be challenging to meet everybody's needs. But we are going to do our best. I want this, even though a webinar is not typically interactive, there's a lot of information to share. Please feel free to ask questions, chat, to add your comments and your own expertise to this presentation. So what to expect? This information is based on CQL's practice guidance for recovery-oriented behavioral health care. And one of the things that I've really enjoyed about CQL is all of the initiatives that they undertake is based on information from the field, information from peers, information from leaders in the field of mental health and research. And they often do that using focus groups, advocates, self-advocates, and clinical people who have lent information. And so the information I'm going to share with you today is really a combination of personal experience, professional experience, and research. We're going to provide a framework for recovery-based organizational change. And let's keep in mind this is guidance, not guidelines. So I can't share with you a recipe. I wish I could. If I had a magic recipe, I would have used it by now. I promise you that. And that's for individual recovery as well as organizational recovery. So we can't give you a formula to go about organizational transformation toward recovery, but we certainly can share with you some of the ingredients. We're also going to include a lesson learned, a lot of tips, a lot of resources, and some examples. And I hope you're not offended by my graphics and animation. I don't mean it to be elementary. You'll see what I mean when we go ahead. But sometimes I feel like when we work in this field, things can feel so heavy and so serious. And we don't necessarily need to be that serious all the time. So that's why I included those. Lastly, we're going to be providing a lot of information. I ran through this and it was an hour of me talking. Trust me, after about 30 minutes I was tired of hearing myself speak. Given that, it is a webinar, so it's not an interactive training. We will be sharing a lot of information with you, so please bear with me with that. There are 4 different components regarding organizational recovery that we're going to focus on. The first is understanding recovery, what it is, really developing that foundation of what we're talking about when we're talking about individual recovery. The second is creating a recovery culture within your organization or within your system. The third is the use of recovery-based practices. And then the fourth is system accountability and outcomes for organizations. And the first is really understanding recovery. Unless we have an understanding of what the process of individual recovery looks like, it's really difficult for us to transform our systems based on recovery. And I find that there can be misinformation or misunderstanding about what recovery is. And so I always like to go to people who are in recovery and ask them to define what recovery means to them. Now I warn you, there is a swear word in here, and I made the decision that I'm not going to say the word, but this is one person's quote of their individual journey of recovery. Individual recovery is letting go of old ideas and embracing new ones. Rather than a should-have, could-have, fear-based mentality, I accept me in all my glorious strengths and see myself as a child of the universe. I was created exactly the way I was meant to be. Kiss my A, i.e. butt, you demons from the past. But when you say the actual word, it rhymes with past, so I'll give you a hint. One of my favorite definitions of individual recovery was that one. The other example that I have is understanding who I am, where I've been, how I got there, and how to forget and forgive to move forward. I will survive no matter what anyone says about me or tries to do to pull me down. We hear this a lot in the world of recovery. Recovery is not about going back, and it's not about staying where I'm at, so that functioning maintenance thing is not really what we're talking about with recovery. We're actually talking about moving forward, looking ahead, and having a life despite experiencing mental health issues. This is just a very simplified description of what recovery is and what recovery is not. Of course, recovery is personally defined, and for that reason, I find that providers can have a difficult time wrapping their mind around what it is. There is a national definition of recovery, but with my experience over the years, I have found that there is no universally accepted one definition of recovery. I can tell you that from what people have shared with me and from my own recovery experience, it's not about stabilization, functioning, or maintenance. And as I said a second ago, it's not about going backward, and it's not about staying where I'm at right now. It's about moving ahead. So recovery is very much a futuristic, wanting to have a meaningful life definition. It's possible and it's probable, and I'm going to share with you some research studies that demonstrate the outcomes and that people do in fact recover. It's not an exception, and it's not only possible for a select few. I hear that sometimes. I do a lot of trainings, and people will come up to me and say, well, you know, you're not like my consumers. You don't act like them. You are able to get up in front of crowds. And I describe to people what my experience was like when I was first diagnosed 23 years ago and what those first 7 to 10 years were like. Because you're seeing me 23, 24 years later as I'm well on my way to recovery. The word recovery is not without controversy. There are people that believe that recovery doesn't really fit the description of the process. So some people prefer words like overcoming and healing and transforming. I like surviving, thriving. Recovery is not formulaic. The last one that I'm going to highlight on this particular chart is that recovery is hard work. There's no magic pills, and there are no treatments or magic interventions. And I wish somebody had shared that with me fairly early on. Instead, I was told, take these medications, go to therapy, do all of these treatments, and nobody ever said to me that if you want to recover, you have to work at it. So that was a huge lesson learned. It's not something someone else can do for you. It's something that you have to do for yourself. People, providers, interventions, those are all tools to help us in the recovery process, but unfortunately, they don't replace hard work. So this is the good news. Organizations, services, and people can absolutely enhance recovery. So they can't do the recovery for us, but they definitely can promote it and help us along that path. And here's the bad news. Organizations, services, and people can absolutely hinder recovery. And we want to make a decision within our agencies and within our roles in those agencies to be the people to push recovery forward, not to be the ones to really hinder that process. You're going to see throughout the presentation there's a series of tips and tools. There's so much information about recovery, and there's no way I could provide all of it in an hour webinar, but I did want to leave you with some examples of tips and tools. One of the best tips I can share with you is to learn about recovery from people. Ask people that you come in contact with, that you're providing supports to. Learn about recovery from the perspective of lived experience. Nationally, internationally, there are numerous people who have been brave enough to share their experience of recovery. Written articles, written books. Go out, look for that information, and learn more about recovery. Under the tools, you'll see a series of technical assistance centers. Those really are national repositories of everything related to recovery, from research to definitional studies to what it is and what it isn't. So I urge you to click on those links and learn more about recovery. We can't be a recovery organization if we don't have the foundation of recovery. The second component to creating a recovery organization is really the culture. And we're going to start with a definition of what is organizational recovery. Organizational recovery is really a process of transformation, and it's transforming that medical traditional paradigm that so many services have been based on to one that embraces and understands and provides supports in a recovery-oriented manner. It's creating an organizational culture that supports and advances recovery. And it's a commitment to understanding and embracing recovery values and principles. Now this one is an interesting one. Providers, organizations, and systems are all at all different places in this process of transformation. And sometimes I think we want to have it done and we want to be done today and we want to do it perfectly. One of the things that I do is compare the individual recovery process and the organizational recovery process. We have to make a committed effort to understanding it and for progress. It's not going to be perfect, and that's okay, but we have to be committed to making it work and to moving forward. And so that's why we said it's not about perfection, it's about a commitment to understanding it and embracing it. Organizational recovery it's about having a genuine reflection. So really wanting to know, how does our organization stack up to recovery principles and practices? It's not about renaming your organization, and I've seen this happen. Nationally, there's a lot of buzz and information about recovery, peer support, psychiatric rehabilitation, and a lot of organizations now use the word recovery in their marketing material. What I say is there is a place to start, but we really need to move beyond that. Doing what we've always done, but calling it something new, is not recovery. It's not a new service to tack on to an existing program array, and that's also can be a misunderstanding. People think, well, we need to add a recovery-oriented service. Organizational recovery is about how you do what you do. And so this is about the entire culture of your agency. It's also more than just providing evidence-based practices, and we'll get into that a little bit throughout this presentation. Just because you provide evidence-based practices doesn't mean that you're recovery-oriented, and that's a debate going on right now nationally in our recovery community. Why are organizations making this transformation? I'm sure each of you have your own reasons for being a part of this webinar, for starting the process or wanting to start the process. One, of course, is outcomes. We recognize that when we utilize a recovery orientation, the quality of our services and the quality of life of the people that we support enhances. Research, we have research now, not exactly research to show what completely works for people, and we'll talk about that in a moment as well, but research that indicates the processes that we can use to support people advance their recovery and some of the interventions that have been proven to be effective with certain outcomes. Funding, you'll see that there's a big funding push to have recovery-oriented organizations and recovery-oriented services, so that's prompting organizations to go through this change. There's a federal push, federal laws that are going into effect, that have gone into effect, white papers and things like that, that are really pushing agencies toward transformation. Program expansion. We recognize that when agencies are recovery-oriented, oftentimes people want to go to those agencies to receive services, and so there are opportunities for expansion there. In staff retention, when recovery-oriented environment is developed, we find that there's more satisfaction and less turnover with employees. So, show of hands. This is a yes or no. Has your organization begun the process of recovery-oriented organizational change? And again, if you can go to that hand. Has your organization begun the process of organizational change toward recovery?
Getting a lot of positive responses.
Excellent. So we actually have a good amount of Yeah, that's wonderful. So you are the experts in this process. I'm sure you've had a lot of lessons learned, as have I, so please feel free to share them. A question that we get from agencies is, where do we begin? I am one of those people that believes that the individual process of recovery can be applied to organizations, and you have to meet people where they're at. So we just need to begin somewhere that makes sense for your agency. We need to meet organizations and systems where they're at, just like we meet individuals where they're at relative to individual recovery. So there are a variety of places that you can begin. I have worked with agencies and systems that have started in different places, different stages, and that's okay. It's the most important thing is that we figure out where to start and we begin. So creating a culture of recovery. One of the active ingredients of organizational recovery is really culture. And culture includes a variety of things. It's the values and the beliefs that the employees, that the organization holds true to. And often you see that reflected in the attitudes and the behaviors of its employees. So if I look at a mission statement and a value statement and I see several things that are listed that are recovery oriented and I compare that to the atmosphere and to the employees, I can learn a lot about what is actually being done in practice and what is being done on paper. It also is the way we provide the services or the practices, which is what we provide, and how they're provided, which is the processes. Now, CQL developed an organizational recovery quiz, and it's not meant to be this very in-depth tool, but it is meant to give us a really general idea, and it's a fun short quiz of where we're at within our organizations. So we're going to have several polls that you can answer. I think there's a total of 7, and you will see that there will be a variety of answers, A, B, or C. Take a quick minute for poll 1, which I believe Beth is going to set up, for question number 1 of our organizational recovery quiz. When people arrive to your organization, are they A, greeted by a peer, someone with lived experience who welcomes them to the organization, B, asked to sign in and sit in the waiting room until they're called, or C, told that they missed their last appointment and will need to reschedule with a clinician? So in general, I know it's not going to be true for every individual, but in general, what do you think best characterizes your organizational recovery at this point?
I'm going to give people just a few more minutes to answer, Shireen. It looks like the percentages are changing, not minutes, but seconds. Okay, we've stayed here pretty well. 38% have answered A. They are greeted by a peer, and 63% of the respondents have they're asked to sign in and sit in the waiting room. Fortunately, 0% are told that they missed their last appointment and have to call in again, have to reschedule.
Premature, and he had to go to the neonatal care portion of the hospital. And he was very concerned about having a sterile environment, and he was very scared, very fear-based. And he walked us through what that process was like, and when he walked in, the pictures on the wall of families and their children when they were in that unit themselves, there were letters from children who were 7, 8, 9, 10 years old telling the hospital staff about their experience and their life since. And it was just generally a positive environment. And he said it was an atmosphere of healing. It wasn't a clinical place that I thought I would have to go to because my child was sick and I wouldn't even be able to touch her. And that was just, it resonated a lot with me relative to the importance of environments. Environments absolutely do matter. Did you have our poll up? Okay, so physical environments reflect the values of the organization. Think about what it feels like to have a healing environment. And it's interesting because I hear people say all the time, when they walk into an environment of recovery, they can feel the difference. The energy feels different. The environment looks different. It's very welcoming and healing compared to a fairly traditional clinical environment. Well, that's what we're talking about. We're thriving to have healing environments. I say sterile, hostile, institutional environments produce sterile, hostile, institutionalized people. And this isn't only true of the people who are coming there for services. This is true of the employees. I don't know if other people have had this experience where they've worked with people who were very institutionalized. The employees were very institutionalized. And one of the tips that we've learned along the way is that physical environment can really make a difference with that. Colors, pictures, inspirational sayings, comfortable furniture, a welcoming atmosphere, all of these things contribute to recovery culture. The second tip is that language matters. How do we start to shift our culture and put our values into action? Well, one of the simplest ways to do so is to begin shifting our language and the language that is commonly used within our organizations. This one is not without controversy. Words that we choose can be very powerful. They can be motivating and inspirational, or they can cut and scar. And the jargon in our behavioral health community is often fairly clinical and based on different diagnostic labels or labels of symptoms. This language can really promote discrimination and stigma, and it can communicate a sense of helplessness and hopelessness. And again, that's not just for the people who walk in who are receiving services, but that's for our employees. If we're using this language of helplessness and hopelessness, we have a tendency to believe that people are helpless and hopeless. So it's not a very recovery futuristic perspective to have. Some examples would be diminishing language, and I hear these things all the time, calling somebody a borderline. Frequent flyers, cutters, I've heard service resistant, non-compliant, all of these labels that can be used in clinical environments that really can be diminishing to people and their potential for recovery. Catastrophizing language, suffers with, afflicted by, so-and-so is plagued with voices. Those terms feel very, very heavy and really don't promote this idea that you can move on and have a mental health issue, that it doesn't have to be this dark, debilitating thing. Patronizing, my girls, my people. Demoralizing, people like that don't get better. Label people, it's important to understand their experience, what is happening in their lives, and how they're using behavior to communicate that experience. There's a culture that goes along with patienthood, and language can really promote this patienthood. We all, as people, wonder periodically, maybe chronically through our lives, who we are and where we're headed, what our beliefs and our values are. That's a pretty common experience. When you have a mental health issue, it can be even more difficult to discover your identity because you can become the schizophrenic. You can become the non-compliant patient or the cutter. And it can really be a double-edged sword that can serve to stop recovery in its track. And I have personal experience with that. Language can really promote stigma, and it can promote self-stigma. When we categorize people and see them as incapable, what can happen is that people can start to see themselves as incapable. And that is the mark of self-stigma. I hear this all the time through providers who say, well, I'm giving so-and-so choice, but they don't want it. They have options, but they're just lazy. They're choosing to sit there. When I hear that, my question is, what is it going on with that person that is prompting them to feel stagnant like that? And it could be not feeling worthy, feeling incapable, being told so many times that you can't do things, and so you start to believe it. So that patienthood attitude, that patienthood identity is really that negative sense of self. It's that self-loathing, that identity based on label. It's lack of meaning and purpose, feeling helpless and hopeless. And in a recovery culture, we want to promote that personhood, that strong self-identity. Who am I? What do I want? An example of that is when somebody comes and they share a concern about an agency, an employee, a practice. That's a good thing. Particularly in a recovery-oriented organization, we want people to have an identity other than passive recipient of services. We want people to feel like they have a voice and to actually have a valued voice in what's going on with the organization. So, trying to understand, for example, with self-harm, why does the person feel like that's the way that they know how to express self-harm? So instead of labeling them a cutter, trying to understand their experience, possibly of trauma or of other things going on in their lives. Trying to understand what the person is communicating through his behavior. What needs are they getting met? And we all communicate through behavior, so you don't have to have a diagnosis to relate to that. And are there subtle and not so subtle ways that we within our organization are communicating that people are helpless, sick, broken, hopeless, or need to be taken care of? Again, we have some tips and tools. Tips are examples of language that we want to be aware of. Tools, different tools on person-first language and relationships and respect and how to use language to facilitate relationships.
Shireen, before you move on to the next section, we had a question. If you could just give a definition quickly of patienthood.
Yes. That's a made-up word. It's a word that I have used, and it really, what I see happening with people is that there's a culture that goes along with being a patient. And, you know, I see that as patienthood identity. And it includes all the things that I said on the right. So it's really more of an identity that I see people take on. Whereas instead of seeing yourself as a person, as a family member, as somebody who is a brother, a sister, you know, having meaningful community roles, you see yourself as a patient. I hope that answered the question, and thank you for that. So tip number 3 in creating organizational recovery. The approach absolutely matters, and there are some who argue that the approach matters more than the intervention. The process of individual recovery can really be nurtured and supported through relationships. Recovery cultures value partnerships rather than paternalism. And it means that we have to start breaking down those traditional clinician-client roles where the clinician is the expert and their role is to tell people what they should do. And the client is a passive recipient of services, and their role is to be compliant and just do what's being told. That approach really has contributed to our system of dependency, where people can be very fearful, again we're talking about patienthood, can be fearful of making decisions because they've never been supported, encouraged, or developed the tools to make informed decisions. So we want to start breaking that down and focusing on a partnership type of relationship. This includes shared power, decision making, personal responsibility, mutual respect. There's an activity that I thank my MEC Promise family for working together to create. And we're not going to be able to do that, but I at least wanted to share with you. It's one of those activities that I see can create a light bulb in people relative to dignity of risk. So I'm going to tell you how to do it, and then you have this slide to refer back to. We hand out a piece of paper and say to people, identify one decision that you have made that entailed an element of risk. And it can be anything. Deciding to get married, deciding to get divorced, relocating, going back to school, having children, switching career fields, any decision that you have made that entailed an element of risk. And that's probably most decisions that we make. And then identify 3 ways that that decision has impacted your life. It's impacted who you are today. So we'll hear from people, if I decided not to move, I would never have experienced these people in my life. If I decided not to go back to school, I wouldn't have the career path that I have now. If I didn't decide to get married, I wouldn't have the children. So 3 ways that that decision has shaped who you are today. And then we ask people to take that piece of paper, put it over their heads, crumple it up, and throw it in the middle of the room and say it never happened. You didn't make that decision because somebody else thought it was too risky. Now who are you? What is your life like now, never having made that decision? And we see this become an aha moment for people relative to understanding the importance of dignity of risk. You lift me and I'll lift you, and we'll ascend this together. That's the ultimate in partnership. Some tips and tools. Support, encourage planned risk and informed decision making. And there is information out there on shared decision making from Pat Deegan and others. You will see that there are some links there to those type of resources, as well as some dignity of risk. And the other one is support wellness self-management. We have to start supporting people to take responsibility for their own lives, their own wellness, and their own future. We can't continue this dependency on services, partly because services are not going to be there. We're seeing services dwindle and dwindle. Secondly is because we don't want somebody sitting in the same seat in a psychosocial clubhouse for 30 years doing the same exact thing that they were doing 30 years ago. We want people to move forward with their lives. Services are a tool. They're not the destination. And that's what we want to start shifting. Tip number 4 for recovery culture. People in recovery have valued roles within the organization. So this isn't simply putting a consumer on a committee. Certainly that's a place to start, but we're talking about valued roles. We're not talking about tokenism. And so do we really as an organization value the feedback and the recommendations of the people that are in recovery, the people that we support? Do we hire people as colleagues, board members, consultants who have lived experience? People who use services should be involved in all different aspects of policy development and evaluation. Selecting which staff to hire, for example, and quality improvement initiatives. So poll number 2. For your organization, how many people with lived experience does your organization employ, and there's a caveat to that, in which they are free to use their personal recovery experience to impact people you support as well as colleagues? So this is poll number 2. How many people do you have working in your organization in which their role is open to sharing their personal recovery experience to impact others? Okay, I think we're having an issue with our poll. So
No, we're not, Shireen.
Are we good?
We're not.
Okay.
About 63% of people have voted. I was just giving them a few more seconds. And I will close and post the results. All right. And share. You can see the sharing screen now. You'll see that it's pretty evenly divided of the 67 or so people that were able to respond between A, B, and C. Do you see the poll, Shireen?
I do. I don't see it large enough to be able to actually view, but
right.
I see.
Well, about 34% answered A, none. 34% answered B, a few, and C, 31% answered, of course, most all of our employees.
Wonderful. So we have a good mix. We do a lot of education with providers on hiring people with lived experience. And peer support is one of the roles, but there are a variety of different positions that people with lived experience have within the organization. Oftentimes what we hear is that we do have people with lived experience who work for us, but they're not necessarily supported to share their experience. I once taught a graduate MSW class, and it was all about mental health recovery. And the students were talking about throughout that process that in their discipline, they were being taught not to share if they had personal experience. And boy, I just feel like that can be such a disservice to people. And so the idea behind that one is not only are we hiring people with lived experience, but do they also feel supported to be able to share that lived experience with others? Employing people who have experience with recovery has a lot of huge benefits within the organization. It certainly demonstrates that your organization values recovery experience and that that is a professional qualification. It illustrates that recovery is possible, and this is particularly important when people are feeling that helplessness and that hopelessness that they'll never get better, when they have examples of recovery around them. It strengthens your organization's services and culture. Advances the recovery of the individuals you employ as well as the people supported. And the next several are actually from outcome studies. Unfortunately, I couldn't share all of the outcome studies, but it's one of those items, if you want a list of outcome studies on peer support or consumers as providers, please let me know. You can email me, and I'd be happy to share that with you. So improved quality of life, engagement, hospital reduction. Typically, what we're finding is the research shows that peer support is as effective as clinical treatment, and keep in mind that consumer-operated services is an evidence-based practice. A lot of reasons I find why organizations are not hiring people with lived experience. I did want to share some of these resources. There is a compendium of recovery measures you'll see at the top right. If you're looking to assess where your organization is right now relative to recovery, some of those are very useful. Of course, information about hiring peers and integrating peers into your team, and information about peer support. All of those things are listed there. It's not an exhaustive list, but it's a place to start. Okay, and I'm recognizing the time. I know we got started late, but I want to move ahead. So component 3 is actually the practices, and this is what gets a lot of attention when we talk about recovery-oriented organizations. We look at the practices that we provide, if they're evidence-based practices or promising practices. These are examples of what a recovery-oriented practice looks like. Obviously, it's person-centered and is strengths-based, that we want to eliminate seclusion and restraints if we're going to have a truly recovery-oriented culture, that they are trauma-informed, that medications are recognized to be a tool that are effective for some people and not effective for others. And so it's used when it makes sense, and it's very individualized and not used when it doesn't. That people want a home. They don't want housing. People want a home that they choose rather than a housing that they've been placed in. So all of these things include recovery-based practices. We're going to focus on the last few. Community-based, we're starting to learn more about what that actually means. We used to think that co-location in the community was community-based. What we're recognizing is that it's not necessarily even about physically being in the environment, which is part of it, but it's actually having valued roles within the community. This is true not only of the folks that we support, but it's also within our organization. Are we reaching out to our community? We call this social capital. And social capital really goes beyond integration and inclusion, and it recognizes that we all want and need valued roles in our community. We want people who receive services to be homeowners and tenants, and to really use their rights and responsibilities in those roles. We want them to be able to work and use their skills and their knowledge, to be good neighbors, strong friends. They obviously, all people contribute to our economy, so shoppers and citizens. There is a connection between social capital and quality of life, and it's well documented. We've learned that reciprocal social ties absolutely enhance recovery. In saying all of that, there's a difference between a support and a service. Oftentimes what happens within organizations is we think that people need a service for everything. They need to go back to school, so we need to have a service for identifying the school that they want to go to, the discipline they want to study, how to apply, going on campus. We want to apply services to everything, and we've recognized that that is not necessarily what helps people to move forward, that it can create this system of dependency. So we want to look at those supports that we all have available to us, invest in connecting people with those resources and supports. Healing relationships are about doing with, not doing to or doing for, and I really like this quote to illustrate that. Tell me and I know, show me and I may remember, involve me and I understand. We're not here to do for people or to do to people. Our role is to help people to do for themselves, and we provide support in that process. Supports are everyday resources, people, places, different resources that we all have available to us. They may be provided through organizations. However, typically they're provided in the community. So next, organizational recovery quiz. In the context of community, your organization, A, conducts an annual plea for donations, B, is at the table partnering with community to solve local social challenges, or C, what? There's a community out there? I never get out of my office. What would best characterize? And Beth, in the interest of time, as they're doing their polls, I'm just going to continue to move forward and let us know when it's done.
Sure.
The next vital component, I believe is vital, I put a lot of emphasis on this, for recovery-oriented services is the role of employment. The role of employment in recovery. Recovery-based organizations recognize the value of recovery as part of the recovery process, and that employment can be a path to recovery. If we think about what messages people with mental health issues receive relative to work, I can tell you the messages that I've heard, either for myself or for others, which is typically it's too stressful, it's not good to go to work now, you lose your benefits, you get benefits, you might as well just sit at home and have benefits, you need to recover before you can work, you need to get better before you can work. So these messages we hear all the time relative to work. When we do believe in work for people with mental health challenges, oftentimes they're relegated to what I call the 4 F's. Food, flowers, filth, and factories. If you have a mental health issue, you can work in the food industry, you can work with flowers or some sort of landscaping, filth, cleaning up, and factories. We want to start recognizing that regardless of whether you have a mental health issue or not, that you can have a career, and you can have a career of your choice. It's not just these type of employment opportunities that people can engage in. If somebody wants to, that's completely different than us promoting that those are the only things people can do.
Shireen, we have the results of the poll.
Okay.
92% of people answered B, is at that they are at the table partnering with their community, and 8% felt like they were conducting annual pleas for donations and such.
Okay, that's excellent. So what can happen in organizations is we are so focused on our 4 walls that we're not going outside of them and partnering with people. And that does a disservice to our organization. It does a disservice to the people that we support. So that number is very good to hear. The next example of recovery-oriented practices, self-help, mutual aid, peer education. Are your employees connecting people to self-help, to mutual support type of entities that can be as vital as services? And then, of course, personal planning. Are we utilizing person-centered planning or other versions of recovery planning? It's an activity that I usually do. I have people spend 1 minute writing down everything that they plan for, and recognizing that planning is such a part of our everyday experience. How much time is spent planning for a wedding? I know people that spend their entire life planning for a wedding, but when it comes to wellness, when it comes to services and supports and moving life forward, personal planning isn't necessarily happening. And so we want to recognize that planning for recovery is absolutely vital to the recovery process. and that the way we develop those plans are as vital as the plan itself. We're not talking about writing up a plan and handing it to somebody to sign. We're talking about that process of really making it meaningful and personal. We're not going to take the quiz in the interest of time because I want to get through the information, but you get a sense of what we're talking about, whether person-centered plans are really used within the organization. A note about evidence-based and promising practices. Oftentimes organizations will say, well, we're providing ACT services, we're providing a clubhouse, we're doing, we're providing evidence-based practices, so we're doing recovery. And here's just a listing examples of different evidence-based and promising practices. However, what's happening right now nationally is there's a debate whether evidence-based practices really equate into being recovery-oriented. Simply because you provide an evidence-based practice does not necessarily mean that you're providing a recovery-oriented approach. And part of it is because evidence-based practice research was done prior to the recovery movement, that a lot of the outcomes that are identified in evidence-based practices, like reduction in hospitalization, number of visits that you have to our clinical environment, those type of things, are not necessarily recovery outcomes. They may be more relevant to clinicians than they are to people with lived experience. And then, of course, evidence-based practice values scientific methods differently than it values qualitative and quasi-experimental designs, and we get to know a lot about what's worked with people and what hasn't through qualitative and quasi-experimental designs. Some of the people that you might want to keep your eye on relative to that debate is William Anthony. He talks about evidence-based processes and how it's as vital to understand the processes that help people recovery, not just the interventions of the practices. Also Larry Davidson. You'll see there are some resources here relative to employment and social capital as well. Okay, we're coming down the home stretch. I know we're running late, and we started late, so I understand for people that have to leave. We're getting into the organizational structure and accountability and outcomes, which is a vital component of recovery organizations. Organizational recovery, we want efficient, responsive, accountable, and outcomes-driven organizations. And we're going to talk briefly about all four of those. Outcome accountability is continually evaluating the quality and the effectiveness of your services. So it's not just enough to provide a service, and it's not just enough to evaluate the outputs, such as did we meet regulations, were we compliant with these standards, how many face-to-face contacts did we have with people, for example. We want to translate that into quality and into outcomes. Are people moving forward in their recovery as a result of the services we're providing? We measure quality through outcomes, and it includes both quantifiable and qualitative outcome measures. It communicates the desired outcomes, and we let employees know, employees involved in the evaluation process and continue quality improvements. Here's an example of what we're talking about relative to outcome evaluations rather than evaluating outputs. Evaluating outputs or process focuses on the standards. The person is assigned to a program. Expectations are defined by the program. When you're an outcome-oriented organization, the outcome is really focused around the person. Every person becomes a sample of one. That can make it very difficult. What does that mean? That means this. We are not looking at these canned outcomes. We're trying to individualize understanding what is important to individual people relative to outcomes, and that's what we want to measure. Program is designed around the person, and performance expectations are really designed by the individuals we serve. And here's an example of personal outcomes versus program outcomes or service or program requirements. Okay, again, we won't take this poll, but you'll get a sense. Our organization, does it listen, learn, and take action? Does it follow regulations at all times? Does it implement creative solutions and evaluates results? That might be a place to start when you're looking at organizational change. Process accountability is the procedures, the methods, the processes that we use to get to the outcomes, and includes several things we've talked about so far. What is the process that we use to gather suggestions and act on those suggestions? What happens if there's a grievance or a concern? Do we say, well, you know, so-and-so always complains about everything, or, you know, those borderlines, they're always complaining about something? Or do we really value that concern and have a process in place to honor that person's concern and really in an unbiased way look into the issue? Are services timely in access? It's fair? Do we have a shared definition of challenges, solutions? So these are examples of process accountability. Administrative accountability is the business that we provide. Are we conducting business with integrity? Do we have established policies and procedures in place that make it okay for staff to make difficult decisions? Are there built-in practices to support flexible and individualized service delivery? And of course, part of that is employing high-quality staff, making sure that they're well-trained, and that we are doing supervision based on reflective practice. And this is just a poll on how involved self-advocates are in your governance of your organization. Again, it reflects the values of the agency. Lastly, we're going to talk about leadership. Leadership is absolutely vital during this transformation. And that really, it's not just about the directors and the executive directors. It's about your board. It's about your COO, your vice presidents, your team leaders, your managers. For recovery transformation to occur, it really has to be ingrained in the leadership, and you need to have that shared vision in leadership. It's crucial to set the tone, the expectations, and the standards for recovery orientation practices, policies, and approaches. If the leadership is using those words in name only, and they're not actually expecting the organization to change its policies and practices, people pick up on that pretty quickly. Effective leaders demonstrate recovery values in all interactions and all practices. They communicate a shared vision. They establish an organizational structure of empowerment. And there should be leadership opportunities within the organization from all people. So it's not just in title alone or positional status. It's believing that we as a team need to take responsibility for improving our organization. Here's some useful resources that I have found relative to organizational transformation. Some of them are different organizational transformation tools. This is an excellent resource, understanding what's called principled leadership by Dr. Bill Anthony. And the national reform efforts toward recovery systems, there are a couple of examples in there. One from SAMHSA and one that comes to us from Connecticut. Okay, that was a very quick way to end the webinar, but I want to be respectful of everybody's time. We will, in follow-up, send you several different things. A PDF copy of this presentation, the practice guidance for behavioral health care, the organizational recovery quiz, we'll send it to you in its entirety, the What Really Matters guide. There is an organizational recovery article that we've developed, that we've authored, that we will send you. And if there's other information that you want, for example, you want that research on peer support, those outcome studies, please email and let me know, and I will be happy to share all of those resources or additional information with you. So, that being said, I do want to open it up to questions, comments, ideas, anything like that.
If you have any questions, if you'll raise your hand, I can unmute you, and we can do it that way, or you can type it into the question section of your, or chat function. Seems like you've given them a lot to think about, and perhaps, Shireen, there may not be an opportunity. Well, here's Lisa. Did you have a question, or was that just that rogue hand popping up again? It was the hand. Okay, thanks, Lisa. Shireen, I don't think, Mr. Johnson? Ms. Johnson, do you have a question?
Yeah, can you hear me?
Yes, we can.
Okay, yeah, Shireen, great job on the website. I was wondering, this is Obi Johnson in Winston-Salem, PATH program, and I was wondering, could you talk a little bit more about you talking about process versus outcome.
Yes.
Could you kind of elaborate on that, or expound on it just a few more minutes, please?
Absolutely. I would love to. I'm going to go back. Hi, Obi. It's great to hear your voice.
Thank you.
Okay, so we're talking about outcomes versus outputs. Oftentimes what we find happens within organizations is that people design organizations and then they measure the quality of their organization around the regulatory requirements. So for example, if you have a service and you're supposed to be meeting with somebody 2 times a month for face-to-face contact, measuring an output is whether that was done or not. Did you follow that rule? Did you meet that compliance standard? Measuring outcomes is about what happened as a result of that meeting. How did that support the person's recovery? Are our services really advancing wellness? And one of the ways that I really like how CQL does it relative to outcomes is outcomes are designed, they're identified by the individual. So no 2 outcome measures, or outcomes I should say, are going to be defined the same way. So if we meet with somebody, we're asking them questions about what's personally meaningful to them, what quality of life actually means to them. And we're using this relationship process of engagement to learn those things. As an agency, what we're doing is then defining that based on the person's definition of the outcome. We're measuring it, and we're using that outcome information to improve our organization. So outcomes in this way are measured by the person and their quality of life rather than the structural components of a model or a program. Did that make sense, Obi?
Yes, it does. It's very
Beth, you're welcome. Beth, do you want to add anything to the outputs versus the outcomes?
No, you did a fine job. Thanks.
Okay. It's a switch, Obi. It really is a shift because I think as organizations we're so accustomed to checking off boxes. And if we comply with the standards, then that means that we're doing a good job. And in outcome measures, what constitutes doing a good job is if people are moving forward.
All right, Shireen, I think I don't see any other hands raised. There's no other questions in the chat box or question box. I was able to respond to one question. We will be mailing a PDF copy of the slides, emailing a PDF copy of the slides to everyone. If for some reason the file is too large, what we might possibly do is post it on our website and send you an email with a link to that.
And I'll stay on for a minute or two just in case somebody wants to ask another question. So I'll linger for a minute. All right. With that being said, thank you all so much for participating this afternoon, and have a great weekend.
Thank you. Thank you.
We still have about 19 people on, but nobody's raised their hand or typed any questions or chat in.
Okay.
With that, I think, Shireen, we're going to end the webinar. It's about 13 minutes beyond the scheduled time, and I appreciate everyone's patience. If you have feedback, you can certainly email it to Shireen. Could you put the slide up that has your email address on it one more time, please?
Yes, I will. ccarrico@mecpromise.com.
You can send feedback directly to that email address, or we may be sending out a survey following for your feedback. We appreciate your time. Have a great day.
Thank you.